HIV. HIV. In the world, 40 million people are living with HIV in 2020. 80% of people do not know where they got it from. In 2005, 2 million people died because of HIV. In 2015, 1 million people died, so it is decreasing actually. HIV virus is a retrovirus and it uses RNA as its genetic material. HIV's life cycle includes two different steps: reverse transcription steps and gene integration step. There are two parts. The humans have made medicines that interferes with these steps. We do the blood test for tracking HIV. So CD4, the T cells, the type of the white blood cell, is important to protect the patient against the infection. The lower the CD4 count before the treatment, the slower CD4 increase during treatment. So CD4 is like a soldier of our body. So for a healthy person, CD4 count is above 500. Let's check out the mechanism of HIV. So first, HIV enters CD4 helper cells, uses cells to copy HIV self, and reduces the functions and numbers of CD4 cells. Secondly, HIV infection indirectly decreases the quality of uninfected CD8 killer T cells, which allows the virus to avoid humans' immune system. Thirdly, HIV infections can cause immune hyperactivation, which may contribute to immunodeficiency at the final. So note that HIV decreases the CD4 cell number so that it gradually decreases the immune function. Let's check out the three enzymes that HIV has. First one is reverse transcriptase, second integrase, third one is protease. So humans have made medicines. Antiretroviral inhibits these each enzymes. Let's check out the first one, anti-reverse transcriptase, NRTI or NNRTI. So what does reverse transcriptase do? So this enzyme is changing HIV RNA into HIV single-stranded DNA, and the same enzyme works to change the single-stranded DNA to the double-stranded DNA. So it is working the both way. And antiretroviral targets this enzyme. So NRTI stands for nucleoside reverse transcriptase inhibitors, and NNRTI stands for non-nucleoside reverse transcriptase inhibitors. NRTI, it is an analog of naturally occurring nucleoside, and enzymes misunderstood this as a real nucleoside, so it put this fake nucleoside to HIV DNA, which is causing HIV virus problem of replicating. We have a tenofovir, abacavir, emtricitabine, lamivudine, or tenofovir. Yeah. NNRTI, these do not mimic nucleoside. We have efavirenz. So NRTI, so today the most commonly used NRTI are tenofovir and abacavir, both used in combination of emtricitabine or lamivudine. So tenofovir, the part of NRTI, so tenofovir disoproxil and tenofovir alafenamide, TDF and TAF are prodrugs of tenofovir. Inside the cells, tenofovir is phosphorylated into its active form. Yep, so TDF has three different salts and could be any of these three salts can matter, so it doesn't really matter. But TAF has not been approved in real life yet. So you can see the three different disoproxil salts. But tenofovir, TDF, is very commonly used antiretroviral for HIV treatment and prevention since 2000. It is approved and legal. Whereas TAF, the lower amount is needed to achieve the same level into the cell comparing to TDF, so it has much lower bone and renal toxicity. However, the disadvantage is that it has not been approved for the use as a pre-exposure prophylaxis, which is PrEPs, and TAF is more expensive because there's no generic yet. Let's check out the very popular drug called Triac. It is first line to treat HIV, which is composed of 2 NRTI plus 1 INSTI. abacavir and lamivudine plus dolutegravir. So Abdullah Triumeq. Note that Triumeq, this medicine can have a lot of interaction with other drugs. For example, when it is used with metformin, it increases the metformin ability. So with diabetes patients, they should reduce their metformin amounts. So they should not use 2 gram, but like metformin 1 gram or less is recommended. Also, it has an interaction with a St. John Wort's drug. Next, Biktarvy. This is also first line, and 2 NRTI plus 1 INSTI. TAF plus M3-cytabine from NRTI plus bictegravir from INSTI. We have a Janvoya. This is also first line, and yeah, TAF from NRTI plus M3-cytabine from NRTI plus the others. So what is PrEP? So until now, all the drugs that are treating the HIV were 3 drugs. However, this is 2 drugs because this is preparing the prevention, prophylaxis of HIV. So it is composed of tenofovir disoproxil 300 mg plus M3-cytabine 200 mg. So these are 2 drugs. You know this is prevention when there are 2 drugs. So what kind of people are using this? So for example, if the person has the partner who is HIV treating patient, or when you go to the sub-Saharan Africa traveling, you can take this for the prevention. So let's check out the second enzyme, the integrase and integrase inhibitor. So what does the integrase do? This integrase grabs double-stranded HIV DNA and takes it to the nucleus of host CD4 cell. An enzyme makes it possible for HIV DNA to insert itself into the host chromosome. Bictegravir, dolutegravir, raltegravir, elvitegravir is having a Grammy trophy. INSTI, it reduces the effectiveness when it is used with other cation, for example, calcium. So you have to be careful about this. Dolutegravir, it is a first line, and it does not have interact with apixaban. However, raltegravir does. So don't take raltegravir, the INSTI, with other calcium tablet because they will have an interaction. Raltegravir merges with calcium and forms complex in GI tract, and it decreases the absorption of raltegravir. Also, this interaction leads to increased HIV resistance. Solution is to change it into the alternative phosphate binder or separate the calcium by 4 hours. So calcium and raltegravir should not be taken together because of the interaction. Let's look at the third enzyme, the protease, and the protease inhibitor prevents the maturation of infectious HIV variants by inhibiting HIV protease. It can be used with booster. We have darunavir, atazanavir, elvitegravir, and ritonavir. So ritonavir is a strong CYP3A4 inhibitor. Note that citalopram is CYP3A4 substrate, and a lot of depression patients use citalopram. So when they are taking it with a HIV patient who are depressed, keep in mind that these are substrate and inhibitor relation. In ritonavir, we don't need any boosting. Well, darunavir, we use it with a booster. So for example, we use it with a corbicistat. Darunavir plus corbicistat, the protease inhibitor, treats HIV, and they inhibit CYP3A4 and reduce the metabolism of drugs that are CYP3A4 substrates. Corbicistat is not an anti-retroviral, and it causes the increase in serum creatinine due to effect on creatinine transport. So it is used to maximize the boost level of other HIV drugs. Corbicistat is such as it increases boost of darunavir, atazanavir, and elvitegravir. Yep, so this is like the treatments, and keep in mind that the first line regimen is 2 NRTI plus INSTI. or 2 NRTI plus others. So first line regimen, there's a Biktarvy. This is like TEBI name. Tenofovir AF plus bictegravir plus emtricitabine, 2 NRTI plus 1 INSTI. So about the HIV drug council, do not stop medicine even though it works well, because HIV treatment is not a cure. It just keeps the viral load suppressed. The viral load in the blood should decrease to undetectable level so that it is uninfectious. If the medicine is stopped, then there will be relapse of HIV virus. So before giving HIV treatment, ask patient if their hepatitis B, do they have it or not, and are they HLA-B 57 positive? Because if yes, then we cannot use abacavir. And if the patient's renal function is okay, because some antiretroviral drugs are excreted renally, and ask if their liver function is okay. After the treatment, the CD4 numbers, the surrogate marker of immune system damage, will gradually increase. About the viral load suppression will happen, and this load is the direct marker of therapy success and limits further immune system damage, regardless of CD4 count. So these two are individual things. So normal CD4 ranges from 500 to 1200 cells per millimeter cube. But when there's a HIV infection happens, then the CD4 will gradually, it will dramatically decrease. Then our immune system will work. So immunoglobulin will come and knock the virus up. So here, this is why we have a upper increased CD4, but this is for temporary. Then from 2 years to 10 years, the CD4 number will gradually decrease, and it'll be less than 500. We need a HIV treatment, and when you use it, the CD4 will rise again like this. So, what is the treatment? So 2 NRTI plus 1 INSTI, and let's check out the difference between the tenofovir, the NRTI. So there are some types of tenofovir. The tenofovir itself cannot enter the blood-brain barrier. However, when you make it as a salt, the TDF salt will enter the blood barrier, and then it can enter the white blood cell. So as a TAF, which is more recent one, but it has not been approved, but it is recent, it can also enter the blood barrier, and it can enter the white blood cell. As you can see, TAF in the blood is just 25 milligram, whereas TDF is 300 milligram. So we can say the TAF has a lesser side effect. Let's check out the HIV testing kit that people can do it in home. This is a finger prick test. However, to make the result, it should be 18 to 90 days after exposure. We cannot just do it directly because it detects the antibodies in our humans to fight against the HIV virus. And for that antibodies to become visible, we need the times. If their result is positive, then the patient has to go to the lab test and get 3 drugs, 2 NRTI plus 1 INSTI, in 72 hours. Let's talk about PrEP. So this is just 2 drugs for people who has not been infected by HIV, but people who want to prevent the HIV. Consists of 2 drugs, tenofovir, disoproxil, malate, 300 mg, the TDF, plus the emtricitabine, 200 mg. Before PrEP, we need to check if the patient already has HIV infection or not. We need to check hepatitis serology and sexual transmitted infection testing. Because if the person already has HIV infection, then we do not use 2 drugs, we use 3 drugs, which is PEP, not PrEP. We don't give PrEP for people who are under 70 years old, or whose creatinine clearance is less than 60 milliliter per minute, or people who does have the unknown infection, or people who already has HIV infection.